So, ladies and gentlemen, dear colleagues, again, welcome to this session, this symposium on health psychological perspectives on COVID-19, organized within the Symposium of the Belgian Association for Psychological Science, the first virtual symposium that we've organized. My name is Stephan van den Broucke. I'm from the Université Catholique de Louvain, where I teach health psychology and health promotion. And I have the pleasure to co-chair this session, this symposium, together with Anne de Smet from the Université Libre de Bruxelles, ULB, also in Belgium. We have a very nice program for you put together. We will talk about health psychological perspectives on COVID-19, and I will try to share a slide with you for the outline of what we will be presenting. So we have about an hour and 20 minutes for 4 presentations. I will start myself by setting the stage on why health psychology is important to tackle COVID-19. And then we will have 3 presentations that give ongoing research and some preliminary results of research in Belgium on how we can use health psychological perspectives to get more grip on COVID-19. And so, first of all, Melanie Beekman and her colleagues Melanie Beekman will present on behalf of the colleagues also from University of Ghent on why we adopt or not behavioral measures of COVID-19. Then Emily Bans and Alex Bigot from UCLouvain will talk about the determinants of 3 important health behaviors during the COVID-19 outbreak. And then Anne de Smet from ULB will, together also on behalf of her colleagues from various institutions, not only in Belgium but also internationally, will talk about an online tool to encourage preventive behavior. So this is what we have in store for you. And I would like to point you out that we will try to make this as interactive as is possible, even though, of course, that's not always easy in a virtual presentation. But nevertheless, I think it's important that apart from the presentations, there's also some possibility of interaction. During the presentations, I would like to ask you to keep your microphone turned to mute and to turn off your camera. When the presentation is finished, or even during the presentation, you can make comments in the chat so that we will record those and look at those, and that if we have some time for questions after the presentation, we will come back to the questions you raise. You can also raise your hand if you want to ask questions. Experience says that if there's very many people raising their hands, we might not be able to really keep track of those, but we will try to do our best. So that's what we try to do, and if that's okay with you, I will start by setting the stage in this presentation on why health psychology can contribute to tackling COVID-19. Why health psychology would matter? Well, I think it is now very clear that COVID-19 is a problem, a health problem that has a huge impact, not only on the health of the population, but also on society. And the measures that are being taken to prevent the virus from spreading, but also to reinforce the treatment capacities, have never been seen before.
Stephan, if I may just interrupt, could you share your screen?
I think I thought I was sharing the screen, but is it better now?
Yes, that's perfect.
Okay, thank you. Thank you for telling me, because I don't know if it is. So there we go. So psychology, of course, is important here, not only to deal with the spreading, but also for the societal consequences. And we've seen a lot of psychological research erupting in the wake of the COVID-19. Also to inform policies. And of course, one of the main reasons is that many of the protective measures to protect ourselves against COVID-19 require behavior change, and not only of health workers, but also of citizens. It's in a way, you could tell this, you could name this the largest behavioral change project in the history of mankind. And in a way, it's a bit surprising that health psychologists or psychologists in general, who are experts in health-related behavior change, have not been more involved thus far in the way to set the policies. But it's not only the behavior change aspect, I think, it's also the fact that because the size and the scale of the problem, there's a need for people to regain control. People have the feeling often that they have lost control, and to regain control, to protect oneself against it, is easy, and to deal with the consequences. I think that's also something where psychology, and more specifically health psychology, can be of interest. And not only at the level thus of informing people to change their behavior, but also in terms of organizational change and policy change. So I would call this downstream, midstream, and upstream level. Some of the examples that you will see in the presentations to follow will make that a bit more clear. But let me set the stage a bit again by looking at the preventive behavior change measures for starters. We've seen that in many countries across the world, including Belgium and other European countries, health authorities and authorities in general have, of course, tried to intervene, and they have tried to enhance protective behavior of citizens. We have seen that the way they try to do that is the usual way. So providing information, issuing health warnings, imposing restrictions for those who did not adhere to the health warnings and information. Now, we've seen that this is sometimes successful, but not always. We've seen that in the beginning of the epidemic, there was a fairly weak public response. I don't know if this is the same in other countries, and the participants in this session from other countries can tell us about that. But we've seen in Belgium that in the beginning there were even parties to celebrate the beginning of lockdown. So we've seen that basically the health warnings did not have that much effect on everyone. We've seen that when the crisis became bigger, there was more adherence, but now that in many countries the measures are gradually released, there's again less adherence. And very often this is then considered as irresponsible or selfish behavior. But we know from health behavior models that this is probably not the best way of dealing with it and accusing people of being selfish or irresponsible. We know that in fact the changes that we've seen, or the variable success of the changes, is due to the fact that we have not really used the knowledge that we have to change behavior. There's many health behavior models, and I've only picked one here, the health belief model, which most of you are familiar with, I suppose. But that model, which goes back to quite some time ago, tells us that if you want people to act on health warnings, they will only do so if they can personally feel susceptible for the problem, when they see the problem as severe, when they see themselves as capable of changing the threat and to reduce it, and when there are also measures to do so. And it's obvious that in the case of COVID-19, these conditions were not always met. Sometimes people did not think they were so vulnerable because they were young, for example, or because they did not suffer from any severe other problems of health. They might also think that they're not very capable to change their preventive actions. So we see that in a way we could have predicted the low response. And that's not only that, also we also see that there's been a huge coverage of the pandemic in the press and in the media. And so that means that sometimes we get avoidance strategies, because when people get too anxious, they will no longer use that anxiety to change their behavior, but they will reduce the anxiety or try to do so. And in some aspects, this could even go to knowledge resistance when people reject the information. So if we want to really change the behavior, we should use that knowledge. We should also see to the need and the possibilities of maintaining preventive behavior, because changing the behavior is one thing, but maintaining the behavior is another thing. So as the virus will still be with us for quite some time, so we are told, I think we have to let go of relying too much on rational considerations, fear appeal and legal restrictions, and we should build much more on motivational insights and insights of motivational psychology. We should also apply the other ways we know about maintaining behavior, and encouraging sustainable behavior change means that, for example, we can try to change the context or modify the context so as to have more protective behavior. So applying nudges, if you like. There's also the enormous importance of new social norms. If we have people who can set the example, people with influence, influencers that set the example, that will be very helpful. And we can hope, we can wholly hope that when we sustain the context and the social norms, we can also develop habit formation, which means that the behavior that is required to protect ourselves and to deal with the consequences of COVID-19 will no longer be consciously elaborated or not need to be consciously elaborated, but become habits, which are much more resistant to change, as you all know. And I think in that context, I think we also want to, we think it's important for people to become much more self-determined. Now, self-determination of behavior is also a matter of information. And this is maybe a bit contradictory to what I've said before. Of course, information is not sufficient, but it is also important and it remains important. And we know that to gain control or to regain control of their lives in the pandemic, people would like to have information and that will help them to deal with the consequences. Now, with regard to COVID-19, I don't think there's a lack of information. There is actually too much information, and not all that information is useful. Some of it is actually wrong or at least very biased. And so this can create confusion. And so instead of adding more information, we should probably help people to find the best ways to deal with this health information. And this is what we find in the concept of health literacy, which in health promotion and health psychology has become very popular over the past years. So the knowledge, but also the motivation and competence of people to find information when they need it, but also and primarily to understand it, evaluate it and apply it. And we know from research in health literacy that quite a large share of the population all over the world do not have enough competences to deal with it. So addressing the challenge of health literacy means that we will have to take the differences in health literacy into account, and we will have to detect and compensate health literacy levels that are too low, and therefore make the system more intelligible. It means that we have to provide information that is understandable and transparent, not be afraid to change, because that's often criticized and say, well, you're changing your views, but there is, of course, an evolution in what needs to be done when. And so I think communicating new evidence is not a shame, should actually be happening. I think we should also acknowledge the fact that when people act on information, this is an active cognitive process. It's not just passive reception of information, it's also active selection of information and of sources information and of information within these sources. So we know from cognitive psychology that selection of information is depending on the context, but also on people's emotions and selective attention. And again, emotions is one of the topics that will be dealt with further on in the presentation by Emily and Alex. So I think it's important to keep that in mind, and not only in order to select information, but also to understand and appraise information about the virus and to judge whether information is useful or not. I think we have to be aware of biases. This could be negative bias. People tend to select sometimes more negative bias, attach more importance to that. Sometimes it can be positive. Sometimes it's those informations that are more familiar. So we just have to acknowledge that information is not just taken in a passive way, but processed, and that these processes can be understood, and that we can take that into consideration. And this, of course, very much also links to countering fake news. Unfortunately, there are some myths about COVID-19 that are very persistent. The fact that it was created in a laboratory somewhere in China, for example, or that it is linked to 5G masts. These are informations that circulate. Also more subtle information that certain parts of the population are less vulnerable than others. So all of these informations circulate and need to be checked. False beliefs are very often also reinforced by false consensus, because people, as I mentioned before, are selective in what kind of information sources they access. And so you can have the effect of an echo chamber or illusion of truth, whereby people will basically keep on hearing the same things that they already believe in, and therefore their false ideas are being reinforced. And that, of course, does not help in dealing with the crisis. So I think there's a task here for governments to counter the fake news by encouraging people to really double check information, the accuracy of information, to also check before they disseminate information. Unfortunately, there are some examples of world leaders who don't do this. I don't have to give any examples in practice, but I think we have the task of taking this also into consideration. Now, all of that was mainly focusing on the individual who is to take action, whether they're citizens or health workers. But of course, I think we also have the task organizations and communities, because there also psychology and health psychology in particular can contribute. I think it's important to know and to realize that there is already knowledge available in communities. I think many of the solutions and recommendations that are sent out are one size fits all, whereas in fact very often this does not really match the needs of particular groups in the society or particular communities. And if we could involve partners at community level and at organizational level that help to implement, that can help to improve the understanding of what needs to be done, explain to the community why it needs to be done, and maybe even make moderate changes in the consideration so that the measures can be made more effective. This will also help to create more community engagement, which can strengthen the capacity of communities to deal with the effects of the pandemic. Actually, it's quite surprising how we've already seen a lot of community engagement in the crisis and a lot of support and solidarity despite the size and the impact of the crisis. I think that shows that there is resilience in many communities, and we know from other crises, that in fact a very important factor is the trust in those who are giving out the recommendations. Now, building community resilience and building community trust are things that we can try to also encourage, and that will give a better basis for the support. So that's what I think can be done at that level. And of course, in order to implement that within organizations, I think we can rely on organizational change mechanisms that we know from psychology as well. So to end this introduction to the session and to the symposium, I think we can safely say that health psychology has quite a lot to add and to bring into trying to cope with this incredibly important disease and this huge problem at world level. I think we should also learn from the crisis. I think it's important for health psychology to realize the importance of infectious diseases, because we've often forgotten about that. We've really in the past very often put the emphasis on non-communicable diseases, and I think fair enough, infectious diseases, as the COVID case shows, is also important. We should also realize that health is not an isolated issue. Again, something we sometimes forget, and I would like to coin here the concept of One Health, which recognizes the connection between people, animals, plant and the earth. And I think we should learn better to respond swiftly to epidemics, and maybe just accept the fact that not everything can be predicted and controlled, which for psychologists is often a very hard lesson to learn. Now, with this, I would like to end my part of the presentation and give the floor to Anne to maybe look at a few of the questions that were raised, and then we can go to the next presentation. I will give the floor to Anne.
Thank you, Stephan, for this nice introduction. Does anybody have any questions for Stephan? Please don't hesitate to just turn on your microphone and ask your question.
Maybe one question I would like to ask to Stephan is how he would envision the collaboration between health psychologists and the domain of public health, and how health psychologists can also be involved in this cooperation with the COVID-19 crisis.
Thank you, Olivier. I think that's a very good question. I think health psychology and public health are in the same boat. I think we should recognize the importance of behavior also in public health. And I think this is beginning to really become the fact. For quite some time, I had the impression that particularly in health promotion, behavior was almost a dirty word, and structures and policies were the magical bullet. But I think as this crisis again shows, it all very often comes down to human behavior and how we can influence it in a sustainable way. So I think there's really a very good occasion here for health psychology and for psychology, or applied psychology in particular, and public health to join forces. And I'm very happy to see that some of those collaborations are already taking place as we speak.
I see we have a question from Rochelle Cairns. Please go ahead. Not sure if someone can hear me. I see we have a question in the meeting chat by Dr. Rochelle Cairns. I'm sorry if I'm mispronouncing your name, but please go ahead and turn on your microphone and just ask your question. If it's not working, you can just type it in the chat and I will ask the question for you. Yes, just go ahead and type it in the chat and I will ask the question for you.
If anybody else has another question in the meantime.
Maybe I have a question for you, Stephan, in the meantime, while we're waiting for Rochelle to type it. You're mentioning the situation in Belgium and what actually we could all be doing better. I know you have a very international scope in your work. Are you aware of any countries that have a stronger focus on these initiatives already?
Yes, I think to be quite direct, I don't know if it's a good example in terms of effectiveness and efficiency, but I know that in the UK, for example, behavioral insights, as they call it, has been more prominently present in advising the government in other areas of public health for quite some time. And I think obviously this will also be the case now in this situation. And I trust that in countries like in Australia or New Zealand, that there's also more involvement of health specialists and public health specialists with a behavioral background to tackle with the situation. As far as I know, this has not been studied, so this is more a feeling rather than a real appreciation that's based on evidence.
I see we have one question from Rochelle now, and then we have the question by Tracy Apton. And then maybe I suggest that we go on to the next presenter. So the question here is, I will just read it out. I'm wondering if you can discuss the challenge of balancing helping people cope with what has been happening with the larger scale health promotion change. Often there is face validity in helping people cope at the expense of larger health promotion issues.
This is a very good question and also a very difficult one to answer, because I think, in fact, it's very true that very much of health promotion has been much longer term. So the idea of building people's capacities and community capacities is not really based on dealing with crisis situations. So I think there's a big challenge there for health promotion and health psychology, also within health promotion, to try and reunite those two. I think it's probably one of the things we'll have to explore in the years to come within health promotion. And I think also that this is going to happen. I think there's already some efforts to try and do that. I don't think that's the answer that Rochelle is actually expecting, because it's not, I don't have the answer yet. But I think this crisis, like other crises, offers an opportunity to look at refinement of the strategies that we have put in place. And very often we think we know how to deal with these things, but then situations like these tell us that we have to balance out things. Of course, I think it's fair to help people in a crisis situation first, and that we then have to look at the longer term effects. That's very often the case in crisis situations, but we should not forget about the longer term effect. It's a very good point you made there.
Maybe I will just read out the question by Tracy Apton, and then we'll go on to the next presenter. And if I may maybe also remind people who've just joined to ask everyone to turn off their mic and to turn off their screen, so no image, only for the presenters. So the question from Tracy Apton is, what do we know about communicating rapidly changing information?
Yes, I think what we know about communication is that we have to be honest in the communication and simple. So there's very often the idea, and unfortunately the press is often emphasizing that when people change, we have seen this with the masks, for example, the mouth mask. In the beginning in Belgium, the idea or the message was it's not really necessary, now it is necessary. And this is often seen that, oh, people are changing their mind, and what are these experts actually saying? What do they believe in? I think we just have to be very clear and say that not necessarily our ideas change, but that the situation might change, and that requires different things that need to be communicated. So I don't think there's any shame in changing the message, but you have to explain why you change the message.
Okay. Thank you, Stephan, for the interesting talk and for the very interesting answers, also very clear answers to the questions. I suggest we move on to the next presentation. And the next presentation is by Melanie Beekman from the Department of Movement and Sports Sciences at the Ghent University. And her talk will be about why we do or do not adopt behavioral measures in COVID-19. And she will present results from 2 surveys. So I will turn off my camera and my microphone. I will give the floor to Melanie.
Yes, is it working well? I hope so.
Yes.
Okay, great. So if it's working well, you're seeing my slides and you're seeing the catchy title we chose for the presentation, Behave Safe, where I will present some of the results, the first results of a study where we focused on behavior and well-being during the COVID-19 pandemic. This is, of course, oh, this is not moving. The slides are not moving. Are you seeing the slides moving?
No, we just see the Behave Safe.
Yeah, because when I press on the button, I will try again.
Melanie, are you on a Mac or on a PC?
Just a regular, but usually it should work. I think you see it now, right?
Yeah, it's cool.
Next slide. Okay. So I was about to say that I'm presenting in the name on behalf of different researchers. It is a collaborative study between different research groups at Ghent University. So you can see them all here on the picture I've included. So usually I start with giving some background on why we did this study, but I think I shouldn't give much more explanation at this point, because we all know worldwide that we were asked to flatten the curve in order to prevent the spread of the coronavirus. We all know that there is no medication or vaccination at this point in time, so we were basically asked to adhere to several behavioral measures. And I've entered the main ones because they are indeed always changing, but the main ones here on the slide. In Belgium, we are asked to wash our hands regularly, to keep distance, and to stay home. Of course, and this was already mentioned in the previous presentation, this I shouldn't tell you that this required really rapid and massive behavior change. And I think we can think about 2 challenges here. First, there is the intention behavior gap. So although we could have the intention to change our behavior and adhere to these measures, that doesn't necessarily mean that we will actually be able to exhibit the behavior itself. So there is a known gap between intention and behavior itself. And then on the other part, this was already also mentioned in the previous presentation, it is also a challenge to maintain that behavior. And I think today, I've counted it, we're at day 70 in the light lockdown here in Belgium. So maintenance is really an important issue more and more. In our study, different studies, I will tell you more about that in a bit, we decided to start from the health action process approach, which we think nicely addresses these challenges I presented on the previous slide. We were used to using this model for studies on other health behaviors, such as physical activity, but also healthy eating and stuff. So that's why we started from this model. It's a nice model because it focuses both on pre-intentional and post-intentional determinants of behavior. Some of the main pre-intentional determinants are self-efficacy, and if we apply this to the current situation of COVID-19 and the behavioral measures, this would be translated in terms of I have confidence in my ability to follow the measures related to the coronavirus. Another one is outcome expectancies, and this would be more stated like if I follow the measures related to the coronavirus, I have a lower risk of getting infected. And finally, we have risk perception. For example, I have little chance to get infected with the coronavirus would be a statement if there is a low risk perception. On the other hand, there are also determinants between the intention to behave in a certain way and the actual behavior, so adhering to the measures. And there we have two interesting determinants which might be at play here as well. On the one hand, action planning. This would be more stated like I know exactly what I'm going to do, how, when, where, if I want to follow the measures. Another one is coping planning. That's, for example, I have already thoroughly considered potential solutions in case I encounter obstacles in following the measures. And then a third interesting point, and this addresses the second challenge that was presented on the previous slide, is the aspect of maintenance. Let me see. Maintenance, okay. And there, I also want to point to the role of barriers or obstacles in maintaining the behavior and resources such as social support, which might facilitate the behavior and the maintenance of it. So that was running you quickly through the model. And now I want to discuss another thing that is presented a lot in the media nowadays, is that we should pay attention to psychosocial well-being during this lockdown times. Here I've presented some of the titles in papers or in newspapers, but also a pamphlet disseminated by the World Health Organization, which gives some tips and advice on how to deal with all kinds of emotions or psychosocial problems or difficulties that arise during this time of lockdown, such as feeling sad or stressed, but also maintaining a healthy lifestyle, don't use smoking, alcohol or other drugs. So I think we can move to the aims of our specific study. We basically had two questions. On the one hand, to examine the influence of the HAPA model determinants on people's compliance with the behavioral measures. And another question was to examine the relation between complying or not complying with these behavioral measures and various indicators of psychosocial well-being. So this is the timeline of our study. Of course, at the beginning, we didn't expect that it would take us 4 rounds now. Maybe there will be even more if it keeps on going. But at this moment, I will discuss with you some of the results of the first 3 rounds. So we had a survey round in the beginning of the lockdown. That was the week of 20th March. Then in April, and the last one not the last one, was in April. The last one is currently going on, so it's still possible to complete this. Of course, after each survey, we quickly looked at the results. We disseminated some of the main results to the public through newspapers, but also our own social media. And based on these results and changing guidelines, we adjusted some of the questions to make it fit with the current guidelines at that point in time. So how did we do this? I think nowadays there is only one way to do research, and that's through online surveys. So we simply spread the link through social media, sometimes via newspapers, and we hoped that snowball sampling, so people sharing it with friends and family, would help us a bit. So I've presented some of the main themes that were questions in our survey. It was a survey that took 5 to 10 minutes to complete. So we asked them about some general questions, socio-demographics, but also related to the COVID-19 pandemic. Of course, we asked them about the presence or absence of the HAPA determinants. We've included some behavioral measures. And asked about compliance with these measures, but also about perseverance and effort in following these measures. And finally, we used promised items to get a look into several psychosocial well-being indicators such as depression, anxiety, anger, sleep, and social isolation. So the results of the first round, we reached about 300 people. This was a mostly female sample, rather young, and most people reported a higher education, so that's university. And there we asked them about the measure of keeping a physical distance, and we see that most of the people were doing well. They reported to do that at that point in time for rather a long time now, and 20% of them were just started following these measures. If we asked them about the HAPA determinants and looked at the relation with adhering or complying to this behavioral measure, we found that in the group who reported that they just started versus the ones that were telling us that they were not following the rules, and also in the group who reported that they were complying to this measure for a longer time now versus the ones that were saying us that they were not following the rules, that these people all scored higher on each of the included HAPA determinants except for risk perception. We also looked at psychosocial well-being here, and you see that most of the average scores in our sample were in the normal range. So that's around 50, except for anxiety, although it's still within the normal range on average. We found that 44% of people in our sample had a score higher than 60, so higher than 1 standard deviation above the mean, and the mean would be a population mean. This is a norm score. That's a score that we would expect in normal situations. So we could say that there were heightened anxiety levels at this first round in the beginning of March. If we look at the results of the second round, so that was around Eastern holidays in April here in Belgium, there we had slightly less respondents, but still a big group. Again, mostly female, a little bit older, and most of the people had a higher education. And there we see that they were doing or reporting that they were doing really well. They almost everyone was keeping physical distance, and there was a new behavioral measure that we included here, which was communicated somewhere between the two rounds of our study. That was the one of staying home, and there we see that the majority of people were doing this from the start and doing this well. So because everyone was adhering or complying well with the rules, we also asked them in this round about the difficulties that they experience with following these rules. So, and here we see that about 1/3 of our sample reported that they would only see them persevere with following the physical distance rule until a specific date. So around that time, they mostly reported that that would be somewhere around now, actually, the end of May, instead of saying that they would do this for as long as needed. So this shows that they were having difficulties. And also, if we ask them about the effort in following these rules, 1/3 reported to experience a lot of effort in following or adhering to these rules. And also, I presented here that 2% of our sample reported that they couldn't cope anymore with keeping physical distance at that point in time. We asked the same things for staying home, and there you see that the numbers are a bit higher, but again, around 40% of the people were experiencing difficulties with staying at home. Although they were doing it well, it took a lot of effort to do so. Again, we asked them about the HAPA determinants, and there we compared the group who reported to experience a lot of effort in complying with the rules with the group that reported that it was taking them less effort or even no effort, and the group that told us that they would only persevere until a specific date, somewhere around the end of May, versus the ones that were telling us that they would do so as long as needed. And there again, we see that these groups score lower on the HAPA determinants, but that was not the case for risk perception. This was not significantly related. Similar results were found for physical distance, so I only presented staying home here on the slides. For psychosocial well-being, we see somewhat similar results as in the previous round. Again, although it's a little bit lower, the average anxiety levels, and still within the normal range, we see that among all psychosocial well-being indicators that anxiety was a bit heightened. We also looked again at the group who were experiencing a lot of difficulties with following the rules, and in these groups of people we see that they were actually significantly scoring lower on all psychosocial well-being indicators presented here on the slides. And then our final round, so these are really recent results. I will only present the results of one question. This was again in a sample of about 2,000 people, mainly female. The average age was a little bit higher, and distribution of education was a little bit different than in other samples, but again, a similar sample as in the previous rounds. And there I will present some interesting comments on an open question where we asked people about the situations or occasions in which they allowed themselves to deviate from the rules. Our goal was here to detect some barriers or obstacles in following the rules. And there, from the open answers teams, that one team that came back a lot was loneliness and missing family or friends. That made it difficult for people to adhere to the rules. But also at the workplace, especially since people started working again, and in contact with colleagues, people experience difficulties with adhering to the physical distance or rule, for example. And also people reported that they prioritized their own mental health above following the rules, and that was sometimes a reason for not following the rules as they should. Also in supermarkets and in contact with other people in supermarkets, it's sometimes difficult to keep a distance from other people. Then a team that also came back a lot was in the case of taking care of children or grandchildren, that people experienced that it was difficult to follow the rule, and that they did this anyway. And then a small portion, but it's interesting to highlight here, of people reported that they simply did not believe in the rules. So that were communicated by the Belgian government. So we might ask ourselves the question: are these barriers or obstacles in following the rules or regulations, and maybe we should look into this some more or pay attention to this in the future. So the conclusions of our 3 surveys up to now is that most people are following the rules, are adhering to the rules, but it requires efforts. Also, the HAPA determinants seem to be relevant in predicting compliance with the behavioral measures, but also the maintenance or the perseverance of complying to these measures. And we saw heightened levels of anxiety in these first 3 rounds. What would be recommendations and future plans here? Of course, to maybe focus more on these HAPA determinants, so outcome expectancies, self-efficacy, and especially action and coping planning seem really relevant at this point here. To detect obstacles or barriers to comply with the rules, and maybe offer solutions on how to deal with these barriers. This can, for example, be done by disseminating infographics. You can see on the slide here an infographic that was shared by us on social media, but also by the Flemish Institute of Healthy Living, where we present the results of our survey, but we have also other infographics with clear guidelines or tips on how to adhere to these measures. And an idea would be in the future, maybe if there is a second lockdown or a second pandemic, to develop an online tool to guide people in complying or adhering to these measures. An idea would be to start from an existing tool that's based or that incorporates these HAPA determinants and is available or was developed in our lab. My action plan for people who know it or not. So that would be ideas for the future. So I like to conclude with saying stay safe, stay healthy, and stay tuned. You can follow our research updates through all these ways here, and if you are willing to fill out our 4th survey, which is still online this week, you can simply enter this link in your browser after this presentation and help us out. Of course, this is only for the Belgian people in this presentation. So thank you.
Thank you. Thank you. I really think this was interesting to get these informations fresh from the computer. There's a little echo. Maybe you can switch the microphone. Okay. I would also like to congratulate you, by the way, for the fact that today you made the national press with some of your research. An interview in the Standaard today. For the non-Belgian attendants, this is a national paper with quite a lot of spread. So some of the results of your research are already finding their way to the national press. In the interest of time, because we also have 2 more speakers, I would like to limit the discussion to 1 or 2 questions at most. But and I look in the conversation that there aren't any questions voiced so far. Some very constructive comments, though, that it's interesting to have used the HAPA model. I'm asking now if anybody would like to ask a question to Melanie. I don't see many people asking questions. I have one to ask you anyhow. So I find it very interesting that you look at the barriers with the open questions at the end. And of course, I think this is really something that we will have to act on also if we really want to understand why people are or are not performing the behavior. Is there any way in which you could also include this already in your, and that you will include this in the next wave of survey? Is this foreseen that you will try to operationalize?
Yeah, we're asking about several things. I think in some way we also would like to look if so the psychosocial indicators that we use, so anxiety, maybe depression or sleep problems, or social isolation, loneliness, but maybe also social supports if we're talking about resources, that we would want to explore if these are potentially barriers in following that. I think maybe we didn't include more questions on that because we don't want to extend the questionnaire some more at each point. But I think in the future we can maybe try to analyze this and maybe use this information for if it's needed in the future. Yeah.
And then another question that is that's also very relevant is, did you see any differences in terms of adherence to the recommendations depending on age or gender?
No, in our study we didn't find really strong age or gender effects, if I'm correct. But yeah, I should also say that's a really predominantly female and younger population, so that was a bit difficult to really explore age effects because I think we didn't reach many male participants and also not many older participants. Yeah.
So all the male participants in this session, please go to the survey and participate in the next round. Thank you, Melanie, for this, this nice presentation. And I think we'll have to make a move and go to the next presenter. The next presenter will actually be two, and that's Emily Bans and Alex Bigot from the UCLouvain. And they will be talking about social, demographic, cognitive and emotional determinants of health behaviors. So, floor is yours.
Thank you, Stephan. I'm just waiting for the PowerPoint. Do you see it?
Yes.
Okay, perfect. So hello, everybody, and welcome to this presentation. My name is Emily, and it's an honor for me and my colleague Alex to present our study conducted during our internship under the supervision of Olivier Luminet. This study is a 4-week online study focusing on the determinants of 2 health behaviors during the COVID-19 outbreak. So if you have any questions, do not hesitate to ask them, and we will respond to them at the end of the presentation. So first of all, let us introduce you to the study and its context, but you will probably be familiar with that by now. So in the early year of 2020, the world has been exposed to the COVID-19 outbreak, soon referred to as a pandemic by the World Health Organization. So this situation has rarely been seen before in our modern societies. Very rapidly, authorities of several countries, including Belgium, had to implement regulations to limit spreading of the coronavirus. Examples of those measures are social distancing, quarantine measures, and of course, sanitary measures. The adoption of those measures that are really typical of pandemics represents a big challenge and has resulted in significant changes in people's habitual behaviors. In this study, we wanted to focus on 2 health behaviors that had to be adopted to face COVID-19. Washing hands, which is a preventive behavior, and limiting social contacts, an avoidant behavior. The aim of the study is to investigate which determinants could predict adherence to those 2 health behaviors during the coronavirus crisis. We have selected several predictive variables based on general sociocognitive models of behavioral change, as well as studies assessing psychobehavioral responses during recent pandemics. It's important to note, however, that our study is mainly exploratory. We had to implement the study very fast in order to collect responses of participants as early as possible. So regarding predictors, the first category of predictors that was included in our study are sociodemographic variables, as they are often included in studies in the psychological field. We have also included the components of the theory of planned behavior. So this is a classical theoretical framework in health psychology that postulates that behavioral change could be predicted by intentions, which are the motivational aspects that will influence the behavior, attitudes, the evaluation that one makes of a certain behavior, so this can be positive or negative, the subjective norms, so this is the perception that people have of the pressure that they have to accomplish a certain behavior, and the perceived behavioral control. So this is the confidence that one has in his or her ability to perform the behavior. We expect that this theory could help us a lot to predict adherence to the behaviors we want to focus on. But it's still important to note, however, that behaviors at stake in the context of a pandemic are very different from classical health behaviors. The context is also very different from classical challenges that health psychologists need to consider, as the COVID-19 pandemic is a novel situation with a very rapid outbreak and progression across the world that initially seemed out of control. These characteristics are likely to trigger strong emotional reactions, and they could be likely to impact health behaviors. This is why it was important for us to also include, next to measures of the theory of planned behavior, measures of emotional states, as well as measures of health anxiety, as they could be other potentially relevant variables to predict the adherence to behaviors. Measures of social inclusion were also added to the study. So now we're going to present the concrete procedure, the measures, and the statistical analysis that we conducted in our study. So we have created an online study, like Melanie and her team did, through a Qualtrics survey. The study was online through a link, was accessible through a link, and it was online from the 18th of March. So this was the first day in which quarantine measures were taken in Belgium, to the 19th of April. Several methods were used for the recruitment of participants, and they were recruited through internet, posts on social networks, pages of different departments here at the UCLouvain University, emails, and classical media were also used. A total of 4,840 participants that were Belgian and French-speaking participated to the study. Almost 3/4 of our sample is constituted of women again. The mean age of our sample is 44 years old, and 73.6 has a high level of education. So we know that our sample is not really representative, but this is probably due to the way we have recruited our participants. So now let us focus on the measures we used. For most of the measures we included, we used Likert scales to assess level of agreement of participants. To assess adopted behaviors, we included 2 items to assess limitation of social contacts and washing hands. So, for example, we asked participants to answer the degree to which they agreed to the statement, "I limit my social contacts." For the theory of planned behavior, we used 4 items assessing each component of the theory, and we did this for the 2 considered behavior. So you can see on the slide an example of items assessing each component of the theory of planned behavior for the behavior washing hands. To assess emotional states, we have used an adapted version of the well-known positive and negative affect schedule. So we modified the original version in order to correspond as closely as possible to the emotions that people were likely to experience during a pandemic. We then conducted factorial analysis that extracted 4 main components that you can see on the slides, and each had sufficient Quanbax alphas. To assess health anxiety, we used an adapted version of the Whiteley index. So we selected 5 items with the strongest face validity of the total of 16 items. An example of a measure of health anxiety is the statement, "I often worry about my health." To assess social inclusion, we based our selection of items on the social commitment and health questionnaire. Again, factorial analysis extracted 3 main components that we called social relationships, empathy, and loneliness, with Quanbax alphas all superior to 0.75. So for example, to measure loneliness, we provided the statement, "I feel isolated from other people." Finally, we asked participants about sociodemographic information. So the main variables assessed in our survey included age, gender, and level of education. So now I'm going to let Alex present to you the statistical analysis and the results of our study.
Good morning, everyone. So now I'm going to talk to you about the analysis and our results. So first, a little reminder of the logistic regression. So for those who are not very familiar with this model, the logistic regression is quite different from the linear regression model. So here our dependent variable is coded as a dichotomic variable. So it's coded as 0 for the non-application of the behavior targeted and 1 for its application. So for instance, for the behavior washing your hands, the proper application, so sufficiently washing your hands, is coded as 1, and the not sufficient hand washing is coded as 0. The analysis aims at determining the probability of applicating this behavior based on different predictors. Now, regarding our results, we're going to focus first on the behavior I mentioned, washing your hands. So overall, you can notice that several variables have a significant effect on this behavior. So a few sociodemographic predictors show an effect on the probability of hand washing, such as being a woman or an older person, that increase the chances people will sufficiently wash their hands. The different subscales of the TPB also demonstrate interesting effects, but we'll come back to those aspects a little further. So here we'll mainly focus on the emotional aspects that predict the frequency of hand washing. I just want to precise that we've considered this behavior as respected when participants said they wash their hands at least 6 times per day. So these bar plots display the mean levels of different emotional states. In general, you can notice that the more individuals are scared, attentive, or demonstrate a high anxiety toward their health, the more likely it is they'll do a frequent hand washing during a day. So not so surprising, emotions relating to motivation, and here I think about being attentive or determined, increase the likelihood of respecting sanitary behavior. But the other results lead us to think that negatively balanced emotions relating to fear, scared, and anxiety can also increase the chances of applying this behavior. Now, about the limitation of social contact, which is the second behavior that we investigated, an interesting effect can be noticed regarding the age. So in contrast to the frequency of hand washing, the older an individual is, the less likely it is he'll agree with the limitation of social contacts. So older people can then be considered as more likely to keep having social contacts during an outbreak. Additionally, another remarkable effect can be distinguished regarding social relationships. So it appears that the stronger your relations with close others are, the less you'll apply the behavior. So inhibiting social interactions can then be considered as highly difficult for people for whom social dimension is important. We'll now focus on the emotional determinants of the application of the behavior. So among participants that applied the limitation of social contacts, 2 emotions were interestingly significant. So what this graph represents is a different distribution of participants that actually apply the behavior for each level of the scale. Now, what we can see is that a majority of our participants said to be rather on the agreeing part of the attentive or determined scale, so in yellow. So the effect of this emotion is actually quite similar as the one presented for the hand washing behavior. What is striking is the opposition of the distribution for the enthusiastic or happy emotion. So essentially, those results implicate that people who rated the highest on the scale for the determination have applied the limitation of social contacts, but it's the people that rated the lowest on the scale of enthusiasm or happiness that also respected this limitation. So overall, being motivated has an effect also on this behavior, but having acute positive emotions will decrease the probability of inhibiting social contacts. I will now talk about the effect of the TPB subscales on our investigated behaviors. So first, as you can see, both the intention to apply the behavior and the attitudes toward it are significant in terms of predicting their application. But what is then interesting is the opposition of the 2 other dimensions as predictor. So whereas the perceived control over the capacity of washing hands frequently can increase the probability to do so, it is the social pressure relating to subjective norms that will encourage people to limit their social contacts. To conclude, all those findings provide useful information about the incentives to apply the behavioral recommendations. Now, regarding specifically the behaviors that we focused on in our study, we've established that different patterns can be distinguished. So for the TPB, the perceived control on the sanitary behavior have a specific effect, which isn't reproduced for the limitation of social contacts. In opposition, it's the subjective norms that have a play in predicting the adherence of the latter. Additionally, different affective processes were showcased by our results for both behaviors. The emotions relating to motivational aspects had a significant effect on the application of both behaviors. But the results regarding acute positive or negative emotions were more contrasted. So indeed, a general anxious state seems to increase the frequency of hand washing, whereas more joyful emotions present an opposite effect on the tendency to inhibit social contacts. So to conclude, our study suggests various implications in terms of preventive behaviors in time of pandemics. So on one hand, our data concerning age and gender, for instance, can be of use in order to identify people at risk of contracting or spreading the disease. And on another hand, different incentives were identified which could be mobilized to predict resurgence or reappearance of such an outbreak. We have now finished our presentation, so thanks a lot for your attention, and please feel free to ask us any question.
Thank you, Alex and Emily, for this very interesting study, very thoroughly conducted. I see we have one question already from Rochelle Cairns, and the question is, when you were measuring frequency of hand washing, how did you account for those who may work in healthcare and have this as a covariate?
I don't know if this is gonna answer your question, but in the logistic regression, we added a few socio-demographical variables at once in one block. And we added actually the fact of working in a medical or paramedical field. So this might control a little bit for this issue.
And if I just can add something, indeed, this variable was significant, as you can expect. So indeed, working in the medical setting was related to a higher frequency of hand washing, while this variable didn't account for any significant effect for the other behavior that we are looking at, the social isolation one. So that was taken into account, indeed.
Thank you. I see we have another question. Pierre, maybe I suggest that you ask the question yourself if it works.
Yeah, it works. My question was regarding the effect of attentive and enthusiastic on social contact, the diminution of social contact. But how do you combine these two results? I mean, you could be at the same time attentive and enthusiastic, or do you think it is, I don't know, exclusive, that you can either be one or the other, or how could it be interact? I mean.
If I can, Pierre, I think it's an excellent question. I think you are just too fast in our process of analyzing the data, because so far we have been looking at direct effects. We haven't been looking at interactive effects, and this is indeed something we should do, especially when we consider these two emotions, because they go in two different directions. So, but a tricky issue is that for logistic regression, there are different controversies of using interaction effects. So that's something we need to be really careful about. But I totally agree that being attentive and the level of determination, we should pay better attention to how it correlates with the level of joy and enthusiasm that we had in the other scale, and see the extent to which we have people who are actually combining these two emotions, because of course it has also big implications regarding possible interventions, if indeed these two variables are interacting with each other.
Yes, thank you. Sorry for the tricky one.
Okay, thank you. Are there any other questions for Alex and Emily? If there are no further questions, then thank you both for the interesting presentation, and I suggest we move on to the last presentation, which is mine. So I will try to share my screen.
Thank you.
Okay, I hope it's visible for everybody. Does it work?
Yes, it's working.
Okay, perfect. Thank you, Pierre. Okay, so as the last presentation in the symposium today, I would like to present the development process of a tool that we developed that was called the Your COVID-19 Risk, or also known as the COVID-19 It's in Your Hands. And the tool is aimed to increase preventive behavior to avoid getting infected, but also to avoid infecting others. And it does so in two parts of the tool. It gives a risk estimate based on what kind of actions that you take already. And it provides a safety estimate, which is mostly based on suggestions on what you could do differently to increase your preventive behavior. It's aimed at the general population, so it's not aimed at, for example, people who are not adopting, who we know are not adopting the preventive measures so well, or who may be more at risk in work conditions, for example. And this has also influenced some of the choices that we've made. As this is a pandemic, and we know that this does not stop at the borders of countries, it was worldwide, or aimed to be a worldwide effort, and we will also see how far the spread is of people who contributed. The purpose of the tool development was to be as specific and concrete as possible, to create a large data set of very detailed information that would be available open access, so that it can inform initiatives from policymakers, but can also inform other health agencies, other health professionals who want to create behavior change interventions. And this fits perfectly with the philosophy of the people who coordinated this initiative from the Academy of Behavior Change in the Netherlands. Now, why do we need this tool? There are some tools out there already. There are, for example, tools that give you an indication of whether it would be useful to contact your GP based on a list of symptoms that you may have, which is, of course, a different objective from what we have. There are some websites that provide information that is rather static. It's not tailored to what you already do, to your own preventive or risk actions. And there's also the Pandemic Footprint Index, which does give you a score based on your own risk behaviors. And this tool was actually an inspiration to start with this development of the tool, but we've deviated from it by also giving suggestions on what you could do differently. And also we have decided not to give a risk score, because that could lead to a false sense of safety if it's low, or too high feelings of anxiety if it's too high. What I will present today is the development process of version 1. This is something that is constant updating. It's a work in progress. For example, the tool that we have launched now asks a lot of information on subdeterminants of behavior, and this information will drive the fine-tuning of version 2. So this is an overview of the countries that have been involved in the development, and also where we have support for the dissemination of the tools. So there are more than 100 professionals involved, mostly epidemiologists, virologists, health psychologists, but also people who are experts in social media, for example, or graphic design. And the tool will be available in 29 languages, and we have 35 countries involved where the dissemination will be supported. This is a project that is not funded, so it runs completely on the free time of the volunteers, and very importantly also on a lot of positive energy and positive reinforcement by the coordinators of the project. The development was based on the recent action approach. We've seen a couple of models already, some have similarities, but why did we choose the recent action approach? It's a model that has been used before to study infectious diseases such as SARS and sexually transmitted diseases. And the recent action approach posits that behavior is largely determined by intention. And intention in its turn is driven by attitudes. For example, believing that you will be able to avoid getting to a hospital if you take preventive measures such as keeping a sufficient distance, by social norms, for example, believing that everyone in your environment also keeps distance and that they would approve if you do so, and self-efficacy, such as feeling that you will still be able to do this even if you're in difficult conditions. The advantage also of the recent action approach is that although constructs are sometimes differently operationalized by different researchers and interpreted differently, there is a template available for the measurement of these constructs in the decentralized construct taxonomy. So these templates offer the possibility to really have uniform measurements also across the different languages. With our aim to inform policy, inform other health professionals when they're creating interventions. What is the focus here is not so much the determinants, but it's the subdeterminants that we find to the left of these determinants. So behavioral beliefs, normative beliefs, control beliefs, these are very detailed levels. So for example, we're not asking, do you think keeping physical distance is good or bad? But we have a whole list of, it's something that will make me feel calm, it's something that makes me feel in control. And so it's at this detailed level that we need the information to be able to create interventions. What also is important in driving the development of the tool is our causal model. So why do we think that when we create something, it will influence behavior? If we take an example from information about others' approval, we might think that if we add this information in the tool and, for example, mentioned others will appreciate why you're doing this, that this will change the subdeterminant or the belief that people might have that if I don't shake hands, if I don't kiss them to greet them, they might think I'm impolite. And this is a subdeterminant of the determinant social norm, which is important, theoretically speaking, to guarantee the sub-behavior of not doing close contact greetings. And all of these sub-behaviors are important to guarantee that people keep a social distance. So this is a causal model. This is hypothesized why we think that how our tool will change behavior. Users will start from the left. They first see the method and eventually, hopefully, it will change behavior. When we're doing research or when we're developing an intervention, we start from the right because we first need to understand the behavior. We first need to know what is our target behavior that can have the most protective effects, to then see, okay, these are the most important relevant target behaviors and the sub-behaviors that are needed. For example, to keep a social distance, you might need not only to keep your own distance, but in some circumstances also tell others to keep their distance. And then we look at what kind of determinants these are influenced by. And then we look at, okay, what are the methods that we know that are effective to change these determinants. So that's where our intervention development started. We wanted to first understand what are the most important risk and protective behaviors. So this started at the end of March. We started from a literature overview that was available. We summarized risk and protective factors, and because the literature that was available at that time, of course, given the fact that this is a very recent situation, not a lot of the research was actually original research reports. We also indicated the strength of the evidence and, of course, gave preference to things that had a stronger statistical evidence or, for example, case reports. Examples of things that were present in that risk overview are having been to an infected area, having used public toilets, or as a protective measure for not infecting others, self-isolating when having been in contact with someone. And this overview was then presented to a number of virologists and epidemiologists in different countries. For Belgium, one of our Mark's Angels, as they are called in the HUMO, participated. And we asked these virologists and epidemiologists to rate each of these risk and protective factors in terms of how relevant they are to prevent getting infected and infecting others, but also to indicate how specific they are. Is this something that is relevant for everyone, or is it just something for people in a certain situation, in certain groups? Moreover, we asked them to give comments so that they would justify why they gave this rating. And this gave some interesting information, for example, when it came to hand washing, and we had several forms of hand washing, washing long enough, washing between the fingers, and so on. They would, for example, say, well, I will still rate this as relevant, even though it's not perfect. Any washing is better than no washing. They were also very honest in saying, well, we can't really rate this because we don't have enough data on whether this is actually protective. This resulted in a list of factors that were not relevant at all, such as, for example, contact with wild animals, which was relevant at the first spread of the virus, but not in this stage. Factors that are relevant for some people, but not for all, and then factors that are relevant for all, and we've already heard these factors coming back as the most important target behaviors. So the physical or social distancing, self-isolation when you have symptoms or you've been in contact with someone who has symptoms, and washing your hands. So these were the target behaviors that we used in the tool. And to use this in a tool and to be able to give people a risk estimate, we also need to know which level of risk is associated with every level of the factor that we're asking. For example, we did not only include behaviors, but we also included age, the country where people lived, and a profession that required a lot of contact. For example, if somebody fills out the tool and says, I'm between 70 or 80, or I'm over 80, should we give the same level of risk to this person over 80 than to the person who's over between 70 and 80? So this list of all the possible answering options in the tool was again presented to specialists to ask them to indicate the level, the degree of risk associated with this. Moreover, we asked them to also indicate their degree of confidence they had to give this risk level. We've seen that even specialists say, sometimes we just don't know enough. And this was taken into account when calculating the risk estimate. So this gave an overview like this for all kinds of answering options. And there's an example of questions that are asked in the tool. And this is then the first bit of feedback that people get in the tool. It's the risk estimate part that gives them, on the one hand, what their risk is of getting infected and getting corona parts on their body, and on the other hand, the risk of also infecting others, whether they keep the corona parts on them or whether they spread them to others. As I had already mentioned, unlike the pandemic footprint index, we did not want to give a score, a specific number that would either give a false sense of safety or too much anxiety. Our first idea was to use a number of risk levels, such as low, medium, and so on. But we did a small pilot testing, which showed that people preferred the visual feedback, and so we used this temperature gauge instead. Now, so far, this risk estimate is purely based on the kind of behaviors that people do. If we want to change this behavior, as you've already heard in the other presentations, we also need to have insight in what drives this behavior and how we can actually change this. This kind of information is currently asked in version 1, so the tool is asking a whole list of determinants. So version 1, the advice that people get in the safety estimate part is based on our causal model, is based on theory, but it's not based on their exact answers yet to the determinants, because that is what will be included in version 2. So what kind of determinants did we ask? And we've already seen or heard a couple of determinants mentioned in the previous presentations that would certainly also be interesting to include in the development of version 2. We wanted to be very detailed. For example, we asked when we are looking at attitudes, we ask them whether this makes them feel normal, sociable, ashamed, helpless, selfless, socially responsible, relaxed, bad, safe, comfortable. It was a very long list of all kinds of experiences people could have, what kind of instrumental attitudes they could have. So it was a very long list. We created 260 possible determinants, which of course is not feasible for any participant to answer. So the approach that was taken was to provide a random selection of these determinants to people, and we asked users to choose if they wanted to answer anything between 4 to 20 items. And then on the whole, based on all the data that we have when we put everything together, we will be able to determine what the relevance is and how much room for improvement there is. All these determinants were measured in detail, but only for one chosen behavior. We chose physical distancing because it was the most relevant across all the countries. And the physical distancing recommendation actually differs between countries. So what was asked was in line with the country's national guidelines. So that is for version 2. What we have in version 1 is based on our causal model, is based on a hypothesized model of what is important as determinants and what kind of methods we can include based on that. And for example, we, as I mentioned, the information about others' approval, but we also used imagery, action planning, reinforcement, mobilizing social networks. And here's an example of what this looks like in the tool. What was important when we chose the methods was that they had to fit within a text format, as the tool will be available in nearly 30 languages, and it's been developed in just a couple of weeks. We were not able to create, for example, videos or images ourselves and to also have these translated in so many languages. So the tool, the methods are currently in text format, but we do have links to other formats, such as a modeling video on how to correctly wash your hands, to songs that are different per country, per region, per language, that show you what 20 seconds of hand washing is actually like, and also links to resources for other support, such as, for example, Facebook groups on what you could do as activities during lockdown. I just also wanted to share some preliminary results, but it's really, we're really running out of time. So let me just mention that the data that we have currently in use is of about 30,000 users in the countries that have already been launched. So what we are looking at now is just users in Flanders, because the Dutch version was launched first. And all the other languages will be launched at the end of this week. The French version has been launched last Friday, so we have data for all of Belgium now, but it's not represented here yet. Just some behaviors that we can share with you. What people do is about 77% really adheres well to the social physical distancing guideline, which is much in line with what we see in the Antwerp Corona study that has a very large sample. About 2/3 wash their hands after close contact with others, and I think what is interesting to see is that much fewer people actually wash their hands after sneezing, which is a behavior you do to protect others and not so much yourself. And even though most people would self-isolate after having symptoms themselves, there is still a small group that would not consider this. So the detailed information on the sub-determinants will be available in the coming days. And as I said, this is a work in progress, so we have many plans to keep going and to have other versions. The tool for the moment is something that is considered as a one-time use. You get your risk estimate and you get some recommendations, but it does not provide much support for maintained behavior. So there are plans to link with other tools and to include more methods for this. And of course, this tool needs to also continually adjust to changing situations. For example, if more people are getting tested, this may be something that we want to include in a risk estimate. So then the only thing that is left for me is to thank all the volunteers that are part of this project, to mention the link, because all the information is available open access, not only how it was developed, but also the anonymous data and scripts to run the analysis. And if we don't have any time left now, I have mentioned my email address for anybody who has any questions.
Thank you very much, Anne, for this wonderful presentation on a huge project in progress, but obviously also based on psychological models and insights, which is really the key topic of this symposium. It is now noon, so
if I may, Stephan, yes. We can take 5 minutes because I was in contact with the other room and I already told people that we were a little bit delayed, so it will be a shame if we cannot take questions. So no problem for having 4 minutes of questions. I also wanted just to add to what you said, Stephan, about the fact that the study of Melanie, there was an article in the Standard. I must add that there is a full page in Le Soir today. And we hope that tomorrow in the Morgen and in La Libre, there will be also echoes to the symposium. And during this symposium, I even accepted a radio interview about some of the results. So it's clearly showing that these data about the contribution of health psychology are of high interest for the media. And that's something also extremely important in this period to convey clear messages to the press.
Thank you, Olivier, for giving us a bit more time and for this wonderful news about the impact of all this work. I don't see any questions popping up in the conversation panel for people who have attended. So people, please do feel free to use the few minutes we have left to ask questions. In the meantime, I have a question for you, Anne. To what extent do people need good digital skills to use the tool?
Yeah, it is very simple to use. It's just a website, so it's made to be very accessible. And we did do some pilot testing to see if it would work for people who had very few digital skills. There were plans to also do a broader user experience study, but we ran out of time. It was actually quite an interesting approach. So it would be different vignettes of types of users had been designed to look for these kind of people where we think they might have more or less problems or different needs. And then, of course, we would look at usability, but this is planned for version 2. So the idea was also to have this out as soon as we could, as soon as it was acceptable. And of course, it does not include everything that we would want, but to continuously use this information to further improve and to expand on everything that, all the plans that are there.
Okay, thank you. Still no other questions appearing. Then I have a question which and you could maybe answer. Oh, I see there's one actually.
Yeah, that's correct. It's not available in English yet. So it was a staggered rollout or a staggered launch, going first with languages that are not spoken so often. So Dutch was one of the first. We've had Romanian that was also launched, and the reason for this was to see if any kind of technical problems would come up, that our system would not crash with all of the sudden so many users. But at the end of this week, all languages will be launched, so everything is ready for launch. So if you are interested and you check again on Friday, then it should be available in English.
Thanks, Anne, for that very clear answer and very promising as well. I have a question for you, but I think if either Melanie or Emily or Alex or anybody else would like to answer, that's fine too. I think the presentations we've had of the data that are being collected now seem to be rather focusing on intentional behavior change and on conscious behavior. Whereas we know also that the environment and the context is incredibly important as well. Not only the social environment, also the physical environment, and that nudging could also become an interesting way and is actually already applied. Is there any way in which, Anne, you or maybe also Melanie or Emily or Alex are thinking of including that perspective in the work that you're undertaking?
Yeah, maybe I'll just answer quickly and then I'll leave the opportunity to the others to answer from their perspective. Indeed, that is one of the things that I mentioned. This tool, for example, does not support habit formation, where giving cues that trigger, such as nudging, would be extremely useful. The plan is of this tool and also the information we get from this tool to closely tie with policymakers, with health professionals who could support a broader view on this. So it is something that we intend to add to this, but not as part of the tool itself, but in the discussions around the tool and all the information that we can provide. Maybe someone else has an insight also on this.
So last call for the other presenters if they want to have a take on this one. I don't see anyone really wanting to intervene. Okay, but anyway, I think we do have, I think time's up anyway. I think we can move on to the next part of the symposium, not ours, but the next one. I think, first of all, I would like to thank all the presenters for their excellent work. And for showing that health psychology has enormous impact, or can have an enormous impact on dealing with this crisis. I think the fact that it is already being taken up by the press in Belgium is great. But I should also thank all the ones who attended. We've had quite a good presence here of people from not only from Belgium, but also from across Europe and beyond. I don't know, Anne, if you're still here, but Anne's attending from New Zealand, so it must be past midnight now for you. So thanks for staying up and attending here. And I think we should see this as a good example of how we can be resilient in organizing meetings, even when the situations are working against us. I think that in itself is, of course, a fantastic opportunity. So thanks very much, all of you who attended. I'm very happy to close off, but I will give the last word to Anne to also say her last words for this symposium.
Oh, I think you've said it all, so I'm happy to close off, and thank you for the opportunity to co-host this with you. It was a wonderful experience.